This morning at the ASH meeting, I presented on an oral session an abstract on the comparison of lenalidomide and ixazomib as maintenance therapy post-transplant. We are all aware that lenalidomide is FDA-approved maintenance therapy for patients with multiple myeloma and is the standard of care, having shown improved progression-free survival and, at least in one study and on meta-analysis, overall survival advantage. We also have seen in the past that ixazomib compared to placebo in the tourmaline study presented last year at the ASH meeting, there was improvement in progression-free survival for ixazomib versus placebo, but nobody has compared head-to-head the two maintenance strategies of lenalidomide and ixazomib. So in this study, we initially had patients get induction chemotherapy, which was not mandated per study what they got, but being a United States-based study, about 88% of patients got a triple drug regimen of immunomodulatory drug with Velcade and Decadron mostly. And what we saw was that after patients got their transplant, they were given consolidation therapy with ixazomib, lenalidomide, and dexamethasone, and they tolerated that treatment well. This was actually reported at the ASH meeting last year, and we were able to show a deepening of the MRD negative results. That was the primary endpoint of the study. However, we also had built in as a secondary endpoint the comparison of lenalidomide to ixazomib, which was the subject of this year's presentation. What we saw was roughly about 90 odd patients in each arm were given ixazomib and lenalidomide respectively. The tolerability of the two drugs was fairly similar. They did have a slightly different side effect profile with somewhat greater gastrointestinal side effects in the ixazomib arm and slightly more hematological toxicity in the lenalidomide arm. These toxicities were, however, mainly grade 1, 2, and very few grade 3, 4 toxicities were seen. There were about a fourth of patients who required to dose reduce the lenalidomide, and about 15% had to dose reduce the ixazomib. But on the whole, the treatment was generally well tolerated. As regards efficacy, after about approximately 1 year of follow-up, the Data Safety and Monitoring Board met, and it was decided at that point to have patients who were taking ixazomib be given the option of crossing over to lenalidomide, mainly because the study, as structured and statistically powered, was no longer going to be able to show that ixazomib was not inferior to lenalidomide. And so, though we this study had no firm power to answer the question of lenalidomide versus ixazomib, because lenalidomide is an FDA-approved standard and we were not going to be able to show that ixazomib was not inferior, we decided to be safe, and patients are now, after discussion with their physicians, allowed to cross over to lenalidomide. Some have done so, some have not. For those who have not done so, they will continue to get ixazomib on the study. For those who have crossed over to lenalidomide or were on lenalidomide originally, if they have side effects, they will be allowed to get ixazomib. So this study will continue to produce, I think, meaningful results even in the future, as we will be able to know what the utility of ixazomib is for those who cannot tolerate lenalidomide, which about 1/3 of patients are not able to do in the real world. So that's not a trivial problem. So we hope that with this study in the future, we'll have more updates that will be useful as well.